Many people with kidney cancer continue to lead fulfilling lives, and this is a guide for newly diagnosed kidney cancer patients, their family, and caregivers. Across this audiobook, we will talk generally about kidney cancer and the common ages of people it affects. We'll talk about the risk factors, the various types and subtypes of kidney cancer. I will talk about receiving a diagnosis and the common signs and symptoms. You'll hear how doctors diagnose kidney cancer and its different staging and grading, discussing treatment options and what will happen next. Please note that all information in this audiobook is correct at the time of publication and aims to give general information you may find useful before and after a diagnosis of kidney cancer. Also note that it is important to follow any specific advice given by your hospital. Nothing in this audiobook overrides that. This audiobook is produced to support you in understanding kidney cancer and the journey you are on. We hope this audiobook will help inform you, your family, and, if you have one, a carer, when guidance and information about your diagnosis is needed. This audiobook provides easy-to-understand scientific knowledge on kidney cancer, alongside practical information on living day-to-day with the disease and the range of emotions you may experience. We understand that your experiences and treatments will be unique to you, and as such, we hope the information and insights provided in this audiobook will help you make informed choices in all areas of your journey. Chapter 1: Kidney Cancer. There are around 13,800 new kidney cancer cases in the UK every year. The incidence of kidney cancer has been steadily increasing in the UK. The rise in the number of tumours detected following a scan for unrelated conditions has contributed to the rise. Kidney cancer is currently the 7th most common cancer in the UK. Chapter 1.1: Kidney Cancer and Age. Kidney cancer more often affects older men, who usually appear healthy. 75% of people diagnosed with kidney cancer are over 60 years old. Nearly twice as many men are diagnosed with the disease than women. It is not unusual to discover a tumour on the kidney incidentally, whilst the patient is having a scan for an unrelated condition. It is uncommon for people under 40 to be diagnosed with kidney cancer. The risk of developing kidney cancer starts to rise between the ages of 45 to 49, though it is highest in people aged 80 to 88. A risk factor is anything that increases a person's chance of developing cancer. Although risk factors can influence the development of cancer, most do not directly cause cancer. Some people with several risk factors never develop cancer, while others with no known risk factors do. However, knowing your risk factors and talking about them with your doctor may help you make more informed lifestyle and healthcare choices. The most common early symptom is blood in the urine, known as hematuria. If kidney cancer is diagnosed at an early stage, there is a good chance of a cure by removal of the affected kidney to prevent the spread of the disease. The more the cancer has grown and spread throughout the body, the less chance the treatment will cure the patient completely. However, treatment can often slow the progress of the cancer. Other symptoms can be less specific, such as tiredness or pain in the side. Some patients get no symptoms at all, and their cancer is found incidentally. Chapter 1.2: Risk Factors for Kidney Cancer. The risk of developing kidney cancer increases with age. You are at higher risk if you are obese or smoke. Men are nearly twice as likely to develop kidney cancer than women. You are also at higher risk if you suffer with hypertension, which is high blood pressure, have hereditary genetic syndromes such as von Hippel-Lindau, Birdhog-Doob, tuberous sclerosis, and hereditary leiomyomatosis renal cell carcinoma, caused by inherited genes, are a long-term user of mild painkillers such as ibuprofen or Nurofen, or have been on long-term kidney dialysis, or have had a kidney transplant. Chapter 1.3: Types of kidney cancer. The most common form of kidney cancer, around 90%, is renal cell carcinoma, or RCC for short. There are several different subtypes of RCC, which are named according to the type of cell that is affected, or the appearance of the cancer cells under the microscope. The most common of these is clear cell, which account for about 75% of RCCs. Other subtypes include papillary, chromophobe, sarcomatoid, and collecting duct carcinoma. This booklet concentrates on RCC, although some of the information should be helpful to any kidney cancer patient. Chapter 1.4 Subtypes of renal cell carcinoma, abbreviated to RCC. Conventional or clear cell RCC. This can be called non-papillary RCC and accounts for 75% of RCC cases. The cancer cells appear clear under the microscope and have large nuclei. Papillary or chromophilic RCC accounts for about 10 to 15% of RCC cases. The tumors have characteristic papillae or nodules on the surface. Chromophobe RCC accounts for about 5% of cases. Collecting duct carcinoma, renal medullary carcinoma, mucinous tubular and spindle cell carcinoma, renal translocation carcinomas, unclassified RCC, the latter 5 of which together make up the remaining 5 to 10% of RCC tumors. Chapter 2 Receiving a diagnosis. The symptoms of kidney cancer. The most common symptom is blood in the urine. Doctors call this hematuria. It may come and go, and not every kidney cancer sufferer will have hematuria. Sometimes you won't be able to see it, but it can still be detected by a urine test. Most people with blood in their urine do not have kidney cancer. It can be a sign of an infection, kidney stones, prostate problems, or bladder cancer. However, it should always be investigated to find out what has caused it. Most kidney cancers are too small to feel, but occasionally you may feel a lump or mass in the area of your kidneys, and you should tell your doctor straight away. You should also see your doctor about any persistent low back pain or pain in your side between your ribs and hip bone, sometimes called the flank or loin. In the early stages of kidney cancer, there may be no obvious symptoms. Many kidney cancers are found simply by chance when someone is being given a scan for another reason. More than half of adult kidney tumors are detected when using an ultrasound scan to investigate other problems. Sometimes, normal red blood cell counts, anemia, or high blood pressure, or hypertension can be symptoms of kidney cancer. Occasionally, some patients experience a condition called polycythemia, or thickening of the blood, which can also be a symptom of kidney cancer. Symptoms of polycythemia are a bad headache and redness of the skin. In about a third of patients, the kidney cancer will have already spread to other organs, such as the lungs, liver, brain, and bones. These patients may experience symptoms of advanced kidney cancer, such as a persistent cough, coughing up blood, or hemoptysis, abnormal liver function tests, headaches, and visual disturbances or bone pain. You must see your doctor if you have any of these symptoms. Typical signs and symptoms of kidney cancer are blood in the urine, also called hematuria, persistent low back pain or pain in the side between the ribs and hip bone, a lump or mass in the area of the kidneys, abnormal red blood cell counts, anemia or rarely polycythemia, high blood pressure or hypertension, long-term tiredness, weight loss and or loss of appetite, running a persistent temperature and sweating heavily, especially at night. There are other symptoms which can be more general and can also be caused by many other conditions, such as weight loss, tiredness, and running a persistent temperature and sweating heavily, especially at night. How doctors diagnose kidney cancer. Currently, there are no screening programs for kidney cancer in the UK. Doctors use their clinical experience, clinical suspicion, scans, and various tests to identify kidney cancer. Your GP surgery. Your family doctor or GP will probably carry out some initial tests. He or she will ask about your general health, examine you and ask for a urine sample. This will be analysed to see if it contains blood. You may also be asked for a blood sample. This will be tested to see how well your kidneys are working. He or she may also perform a physical examination to check for any lumps or swelling. However, small tumours are difficult to detect on a physical examination because the kidneys are deep inside the body. Your GP may then refer you to a hospital specialist for further tests, especially if you have blood in your urine. There are special referral guidelines for GPs to help them decide who needs to be referred to a specialist urgently. Hospital. The hospital specialist will want to know about your medical history, symptoms, and any medications you're taking. If anyone else in the family has had kidney cancer, you should mention this. You will have more blood and urine tests, such as a full blood count, FBC, and urea electrolytes, UNEs, to test the function of your kidneys. If you want to know the results of your blood tests, please ask your doctor to explain them. Possible tests you may be asked to have. Ultrasound scan. A sonographer will carry out an ultrasound scan, which is a real-time moving test used to detect and differentiate between tumours and cysts on the kidney. This is a painless procedure that is carried out in the hospital scanning department and only takes a few minutes to perform. You lie down and gel is spread on the right and left side of your abdomen. A small probe, which produces sound waves, is rubbed over the area. The sound wave echoes are detected by the probe and turned into a picture of the organs and structures inside your body by a computer. Cystoscopy is a bladder inspection. If you have blood in your urine, your doctor might want to carry out a cystoscopy to check inside your bladder. The procedure is usually done under local anaesthetic. A fine, flexible tube with a light in the end, called a cystoscope, is passed up your urethra, water pipe, and into your bladder, where it acts like a telescope, allowing the doctor to see inside. The initial investigation to confirm you have kidney cancer, you will need more tests to help doctors to see if it has spread and how best to treat it. However, some of the following tests may also be used when your doctor is still trying to determine whether you have kidney cancer or not. CT scan. Computerized tomography, known as a CT scan, is a special type of X-ray examination and is conducted in the X-ray department of the hospital. A CT scan is used to check the size of the tumour and whether it has spread to other organs, such as the lungs and the other kidney. Questions you may want to ask your doctor. Which tests are you going to do? What will happen and how long will it take? Will it be painful or uncomfortable whilst having the tests or procedures? Will there be any after effects of treatments or interventions? Can I bring someone with me? How long will the results take? Who will give me the test results? Will they show if I have kidney cancer? Will they show if the cancer has spread? Once I've been diagnosed, what happens next? The CT scanning machine takes a series of X-ray pictures of your body from different angles. The computer puts these images together to give a detailed image of the inside of your body. You will need a full bladder for this examination, so you'll not be able to go to the toilet beforehand. The machine is shaped rather like a ring donut. You lie on a couch which slides backwards and forwards through the hole. The radiographer cannot stay in the room with you during the scan, but will be able to see you on a monitor and talk to you through an intercom. You may be given an injection of a special dye or contrast agent into a vein in your arm to help blood vessels show up more clearly. You'll need to drink water before and after the scan to flush the contrast through the kidneys. This can cause a shivery feeling through your body. A CT scan is painless, but takes longer than an X-ray. The length of the whole procedure depends on how many pictures are taken, but expect to be on the couch for about 15 minutes. Some people feel a little claustrophobic during a scan. If you think you might, Tell the radiographers before the day of your appointment. Biopsy. Doctors can usually make a confident diagnosis from a CT scan alone. Sometimes a biopsy will also be carried out. Using ultrasound or CT scan to locate the kidney, a thin needle is put through the skin and muscle into the kidney to remove a small sample of tissue. This is then examined under a microscope to check for signs of cancer. You'll need to be observed for about 4 hours after the biopsy. You'll be given a local anesthetic to numb the skin. MRI scan. Magnetic resonance imaging, MRI, is a type of scan that uses magnetism instead of X-rays to construct a detailed picture of the inside of your body. MRI is used to check the size and extent of a tumour and to determine whether or not the cancer has spread to other organs of the body. You may be given an injection of special dye or contrast agent into a vein in your arm to help the tumours show more clearly on the MRI scan picture. Bone scan. You might be asked to have a bone scan to see whether the cancer has spread to your bones. If so, you'll be injected with a mildly radioactive material and then asked to wait for a couple of hours while it travels through the blood and collects in the bones. Areas where there is damage to the bone will show up as hot spots. These aren't necessarily the result of cancer. If you have arthritis, for instance, this will also show up on the scan. Chest X-ray. A chest X-ray may be carried out to check your general health and make sure that you are fit enough to have certain treatments or surgery. It will also be used to rule out cancer spread to the lungs or chest bones. However, you may not have a chest X-ray if you have a CT scan that has included your chest on the scan. You'll be asked to go back to the hospital for the results of your tests. This may take a little while, and you'll probably feel worried and upset during this time. Is there anyone you can share your feelings with? Is there a clinical nurse specialist you can talk to? Before your doctors can discuss treatment options with you, they need to know how far your cancer has progressed and how quickly the cancer is growing and spreading. This is called staging and grading. Staging is used to describe how big a cancer is and how far it has already spread. Information from the tests and scans used to diagnose your cancer is used to determine the stage of your disease. The TNM system is a common system used for staging tumours. The letter T, tumour, plus a number indicates the size of the primary tumour and how far it has grown. The number refers to the stages described. T, 0. There is no evidence of primary tumour in the kidney. T1. The tumour is less than 7 centimetres in size and is completely contained within the kidney. T1A is a tumour less than 4 centimetres in size. T1B is a tumour between 4 and 7 centimetres in size. T2. The tumour is more than 7 centimetres in size and is completely contained within the kidney. T2A is a tumour more than 7 centimetres but less than 10 centimetres in size. T2B is a tumour more than 10 centimetres in size. T3. The cancer has spread beyond the kidney to the tissues or organs around the kidney. For example, a major vein or the adrenal gland. T3A is a tumour that has grown into the renal vein or the fat surrounding the kidney. T3B is a tumour that has grown into the vena cava below the diaphragm. T3C is a tumour that has grown into the vena cava or wall of the vena cava above the diaphragm. T4. The cancer has spread beyond the tissues or organs around the kidney to more distant organs in the body. N, standing for nodes, plus a number, indicates the cancer has spread to nearby lymph nodes. The number refers to the number of affected lymph nodes. N0. Cancer has not been detected in any lymph nodes. N1 cancer has spread to one nearby lymph node only. M, standing for metastases plus a number, refers to places elsewhere in the body where the cancer has spread. M0 means there are no distant metastases. M1 means distant metastases are present. Your doctor will combine these figures to give an overall staging, for example, T2N0M0. which means the cancer is bigger than 7 centimeters but still confined to the kidney. There is no involvement of lymph nodes and there are no metastases. Another staging classification which is sometimes used for kidney cancer is a number system. The cancer is simply said to be stage 1, 2, 3 or 4. Again, the stages reflect how large the primary tumour has become and whether the cancer has spread to lymph nodes or other areas of the body. Stage 4 tumour is often referred to as an advanced cancer. The number system used for kidney cancer is as follows. Stage 1. The cancer is confined to the kidney and is less than 7 centimeters in size. Stage 2. The cancer is bigger than 7 centimeters but still confined to the kidney. Stage 3. The cancer has started to spread outside the kidney to the adrenal gland or a major vein nearby. The cancer may have spread to no more than 1 nearby lymph node. Stage 4. The cancer has spread to nearby tissues or organs, and more than 1 nearby lymph node contains cancer cells, or the cancer has spread to other parts of the body further away. Finding the stage of a cancer helps doctors to advise on what is the best treatment and gives them a reasonable indication of the outlook, prognosis for your cancer. It also describes the cancer in a standard language, which is useful when doctors discuss patients and when patients are involved in clinical trials. When discussing your treatment options, your doctor will also take into account how well you are overall. The frequency of follow-up will be determined according to your risk of having recurrence of kidney cancer. This is often predicted using the Leibovitz score, which is calculated from your pathology results. This allows us to know whether your kidney tumour was classed low, medium, or high risk for recurrence. Frequency of follow-up is according to risk. Doctors grade cancers to indicate how quickly or slowly a cancer is likely to grow and spread. Cells from a sample of the cancer, a biopsy, are looked at under the microscope or tested in other ways. By looking at certain features of the cells, the cancer can be graded as low, intermediate, or high grade. This system is called the Fuhrman system. Grade 1 or low grade cells are usually slow growing, look quite similar to normal cells, tend to be less aggressive and are less likely to spread. Grade 2 or intermediate grade cells grow more quickly, look abnormal, are moderately aggressive and could spread. Grade 3 or high-grade cells are likely to grow more quickly, look very abnormal, tend to be more aggressive, and are more likely to spread. Grade 4 or high-grade cells look very abnormal, grow very quickly, and are extremely aggressive and are very likely to spread. Discussing your treatment options. Ideally, a team of specialists, called a multidisciplinary team, or MDT for short, will be responsible for your care and treatment in the hospital. The team will include a urologist, a doctor who specializes in diagnosing and surgically treating urinary, bladder, and kidney problems, radiologists, oncologists, and specialist nurses. Preferably, all will have experience of treating kidney cancer. The urologist, and if appropriate, the medical oncologist, will be responsible for your treatment and will discuss your treatment plan with you. Other members of the team may include a dietitian, a physiotherapist for post-operative complications, an occupational therapist, and a psychologist or counselor. The team might also include a clinical oncologist, a doctor specializing in radiotherapy treatment for cancer. The team might also include a clinical oncologist, a doctor specializing in radiotherapy treatment for cancer if you're scheduled to have radiotherapy for cancer that has spread. Your doctors will tell you which treatment they think will be best for you. Sometimes they may offer you a choice of treatments. In any case, you should be sure you have been given enough information and understood it before you give permission for the treatment to start. Don't be embarrassed about asking people to explain things again. And remember to ask about any aspects that are worrying you. Pembrolizumab, Keytruda, is approved in the UK as an optional adjuvant treatment for renal cell carcinoma for patients at increased risk of recurrence after nephrectomy with or without metastatic lesion resection. Clinical trials. You might be offered a clinical trial as part of your treatment. When doctors are uncertain about whether one type of cancer therapy is better than another, or if a new treatment or drug is likely to work or have side effects, they try to answer this by involving patients in clinical trials. During a clinical trial, detailed information is collected about each patient, drug side effects, and how well the treatment has worked. You should be told what type of treatment the doctors are advising, how and when this will be carried out, the advantages and disadvantages of this type of treatment, any possible other treatments that might be available, any significant risks or side effects of the treatment. It may be useful to write down a list of questions to take with you to the appointment. It's also a good idea to have a relative or friend with you when you're discussing your treatment options. They'll be able to take notes or help you remember what was said. If you feel you can't make a decision straight away, ask for more time to decide. You may want a second opinion, especially if you feel your doctor does not have enough experience in treating kidney cancer, or if you are told little beneficial treatment is available. Most doctors will be willing to refer you to another specialist, but it may take a little while to organise. As this may delay the start of your treatment, you need to feel sure it will be worthwhile. You may find the decision to go ahead relatively easy if the treatment you're being offered aims to cure your cancer. But if, instead, the aim of the treatment is to control the cancer for a period of time, it may be more difficult to decide. You might want to think about your quality of life while you're having treatment. Will you have to travel back and forth to hospital? What are the side effects of treatment? Can the side effects be treated? As well as talking things over with the people who mean most to you, you may find it helpful to talk to a counsellor or a specialist nurse. If you choose not to have treatment, you can still be given help to control any symptoms you have. This is called palliative care and can be offered to help patients through their entire cancer journey. It can be very difficult to predict what will happen because every patient is an individual. Of course, the earlier your cancer is detected and the sooner treatment begins, the better your chances of long-term survival. Even if your cancer has spread, making it more difficult to treat, it is possible for the symptoms to be kept well under control for years. And in some rare cases, patients may go into remission for no apparent reason. What happens next? Once the diagnosis has been made, you'll be referred to either a urology surgical team or an oncology team, and in many cases, a specialist clinical nurse. How you can self-help. Regular exercise can help you feel better both physically and emotionally. Ask your doctor or nurse what kind of exercise would be suitable for you. Many people find that complementary therapies, such as massage, aromatherapy, meditation or visualization, can also lift the spirits, ease tension, and restore a feeling of well-being.